Okay. Okay. So drugs affecting the renal, urinary, and also cardiovascular system. Okay, and this is chapter 8 in your book. Again, you want to know about the key terms, um, which includes your adrenergics, your alpha adrenergic agonists, and beta blockers, calcium channel blockers, the renin angiotensin aldosterone drugs, which are drugs that include the angiotensin type drugs, which can basically higher your blood pressure, lower your blood pressure, and some other drugs. So we're going to look at drugs that affect the urinary system, and then we're going to look at the drugs that affect the cardiovascular system. Um, so just to kind of do a brief overview of you always want to do a brief overview of your system, the urinary tract system itself, and the cardiovascular system, because the renal and also the urinary system, they work very well together. The cardiovascular system is there to maintain and help circulate and make sure bloods are actually going to all parts of the body, whereas your urinary system is going to be your filtering system to remove the waste products that's not needed and waste products that's probably causing you to have different types of symptoms such as diabetes, high blood pressure, and all the other above heart conditions and kidney failures and so forth. Well, not kidney failures, but heart conditions. Um, but drugs that affect the renal and urinary system. So you have your renal slash urinary system, and just kind of know how that works. You want to go do an overview to look at that and how that whole system works. So now when we get to certain drugs that are going to be used on it, if you know exactly how the system works, it'll kind of give you that broad, like, okay, so this is how it works, and when it's not working, this is why we need to take certain medications. So the first set of medications are your diuretics. And we're going to look at diuretics and other drugs affecting the urinary, and other drugs affecting urinary tract. Okay, let me just okay. So now you're going. So sorry about that. Okay, so now you're going to have the medications that can actually work to, um, depending on the issue and the problem that you may have. Because remember, you have the whole cardiovascular system and the urinary tract, and also the renal system, all working together to kind of help to filter the body out. So sometimes, if you have a condition like congestive heart failure, hypertension, swelling, edema within the body, we'll kind of flush them out. So these are what the diuretics and some other drugs affecting the urinary tract can actually help do. So your diuretic action, so they indirectly reduce blood pressure by producing sodium and also water loss, and lowering the tone and rigidity of the arteries. And you have your different types. You have your thiazides, your sulfonamide diuretics, your loop diuretics, and also your potassium sparing diuretics that you have. So you want to look at the diuretic drugs, what their main action is. It's going to decrease the fluid volume by increasing the urine output. So decrease fluid volume by increasing the urine output, because you want to get that out. You want to push it out. So, so you want to make sure that you're doing that. Okay, hold on. Let me see something here. Okay. Um, so by the body way of doing that, you know, it's going to help relieve that high blood pressure and get all that fluid out. So you're gonna have different diuretics. So to actually do that, and depending on that type of diuretic that's going to help do that, it's going to each of them have their own little action that's going to be you know noted here. So you're going to have the sites of diuretic action. For example, if somebody's on a potassium sparing, they're going to be like over here somewhere. If somebody's on a thiazide diuretics, they're going to work over here. And if they're actually here in the loop of Henle, they're going to work here, because it's going to be basically, you know, trying to filter out the sodium. But the potassium sparing will do the same thing, but at the same time, they're going to be sparing the potassium, keeping that in. You know, sounds good, but then, you know, like if it's one of those diuretics, for example, that pulls out everything like sodium and everything else, you want to replace it. But the potassium sparing, you don't want to replace the potassium, because that's going to cause problems such as, you know, affecting the heart, because there's going to be too much potassium in the blood. So certain ways that, and you know, it has to be balanced out in regards to when a patient's using some diuretics. So diuretics, again, they're going to be in the 4 different groups, like we've seen before: the diazides, the diazide-like sulfonamides, and the loop diuretics, and also the potassium-sparing diuretics. Okay, but the most effective type of diuretics you're going to see, those are the drugs that actually work at the ascending loop, um, in the nephron, which you would see over here. Okay, ascending loops of the nephron. Okay, now, as a memory jogger, just to remember the 4 categories of the diuretics, I'm trying to see if they have it here. They actually put it here. No, yeah, they did. Thiazide, sulfonamides, loop diuretics, potassium sparing. Okay, so it's 4 different types. Okay, so you have the 4 different types. So the thiazide is going to be the thiazide diuretics. The sulfonamide, this right here, are thiazide-like sulfonamides. Okay, here the loop diuretics, and you have the potassium sparing diuretics. But it's 4. It's going to be 4 main categories, and you'll see that better in your book than here what's on the slide. Okay, so now what are the actions of these, what are the actions of the thiazide and the thiazide like sulfonamide diuretics? Okay, so there is not, for some reason, this whole thing here. Okay, here we go. Don't know what, I didn't do these slides, like I said. Trying to match up the slides on my notes, but okay. So let's talk about the thiazides and the thiazide-like sulfonamide diuretics. So the okay, let me just. I am sorry. So for some reason, having problems on this side of my computer. Okay, great. Okay. So the thiazides and the thiazide-like sulfonamide diuretics, they work at the end of the ascending. They work at the end. They work over here at the end of the ascending loop of Henle, and at the beginning of the distal convoluted. That's the distal convoluted, which is over here. Okay, so that's where they work. Okay, so um, and inside the nephron. So these drugs, they're going to increase the urine output by preventing the water, sodium and potassium and chloride from going through the walls into the nephron to be reabsorbed back into the blood, where if it goes back into the blood, it's going to cause a lot of problems. Okay, so they are not reabsorbed, because you want they're not reabsorbed at all. So you want to really get them out. You want to excrete them out. So you have the different types of those. So you have the common diuretics, and you have the common diuretics, which are your thiazides. And these drugs, again, is going to work to lower the blood pressure. It's going by increasing the urine output and preventing all that sodium that's going to increase the blood pressure, all the potassium that's going to elevate, you can elevate your heart rate and the chlorides and so forth, all those electrolytes that you does not really need it right now in your body because it's too much. So they also going to they also dilate the arterioles by relaxing the smooth muscle in these blood vessels. So what are those medications under the thiazide category? You have the diurils, you have your hydrochlorothiazides, you have, so you have those, and those are going to be given orally. You rarely see them given, through an IV. You can always see them given orally, usually daily, to a patient. Again, when your patient come in, you always want to get a baseline, the patient's weight, especially if they're on diuretic, because number one, you want to monitor, any um, weight gain, and also monitor and prevent any type of dehydration when they're on this medicine. Because when I say pull out, it pulls out. You're going to be monitoring the potassium levels, so it won't, make sure that the potassium levels are good, because you want to assess that they are within normal levels, because these drugs, again, is going to reduce the potassium level. And sometimes the doctor may have to order like a potassium supplement and so forth. So you want to monitor the patient's in all the labs, any type of electrolytes and so forth. That's going to include the BU and nitrogen, because again, you're looking at any type of dehydration. If the patient does have diabetes, you're going to monitor his or her glucose level carefully, because these diuretics can elevate, even though they're pulling out fluid, they can, at the same time, they can elevate, your glucose level can be elevated. And you want to hold the diuretic if the patient has a blood pressure less than 90 or 60, because this can be symptoms of dehydration or any other kind of adverse effect. Right? Now, thiazide, like thiazide like sulfonamides. So remember, when we think of sulfonamides, you're thinking of, thiazides, you think of anything that can elevate sulfur. So you're thinking of like that's like a sulfur. So like thiazide diuretics, these lower the blood pressure by preventing the sodium, the potassium, the chloride from going through the walls of the nephrons to be reabsorbed back into the blood, where you don't want that to happen. And they also dilate the arterioles by relaxing smooth muscles into these blood vessels. So you're going to be seeing your Xeroxilin. Some patients may be on that. Again, you're going to be weighing your patient, getting that baseline. You're going to monitor for preventing dehydration. You're going to be monitoring their potassium levels. You're going to report any type of potassium level that is less than 3.5, to the healthcare provider, because any type of low potassium level can have a serious effect on the heart rhythm. So you want to make sure of that. Then you're going to have your loop diuretics, and the loop diuretics work a little bit differently. The loop diuretics where it works. No, it works in the same way, but more closer to the loop or Henley. So your loop diuretics works to increase urine output by blocking active transport of chlorine, sodium, and potassium in the thick ascending loop of Henle. And those are going to be for example, your Bumex. You'll see that, or butanamides. Again, you want to look at all those nursing implications. You want to remind the patient to stand up slowly, because you want to avoid any type of ortho hypostatic hypotension. Then you're going to have the category of your potassium-sparing diuretics. And these drugs are going to increase the excretion of the water and the sodium, leading to increased urine output, but you're not going to lose the potassium. The potassium is going to be there. So that's why it's called potassium-sparing diuretics. And these are going to act by slowing the sodium pump in the distal tube of the nephron, so more sodium and also water is excreted out into the urine. And those will be your adaptones and your diurenium, so you'll have those. Again, with those, you're going to monitor potassium levels just to assess whether they are within normal levels, because the higher the normal blood potassium levels can occur with these drugs. So your potassium will still be there building up even though everything else is draining out, your potassium can build up. So again, when you're reporting and looking at the potassium levels, if it's greater than 5.0, the healthcare provider needs to be notified because this can cause any type of cardiac problems. So those are some of your patient teachings in regards to those types of common diuretics that the patient may be prescribed. So again, when it comes to the life considerations, pregnancy, breastfeeding, you have your thiazide diuretics. There are some, they're approved for the use during pregnancy and may be used in low dose for breastfeeding mothers without any type of adverse effects. The most powerful diuretics are usually not recommended during pregnancy, unless essential for the mother's health. So high doses of diuretics for breastfeeding women may suppress lactation. And again, just remember your different groups. You have your loop diuretics, you have your potassium sparing diuretics. Always look at the uses, the common effects, the the adverse effects and the expected side effects. Again, your expected side effects would be urinary frequency, dry mouth, anything that can lead to like dehydration, like symptoms like lightheadedness. The adverse effects of it would be, diuretics because they increase the urine output. So again, dehydration can be that part of it. We said high potassium, if it's a potassium sparing diuretic, low potassium, if it's a loop diuretic. So those things you want to look at, and make sure that you're looking at the labs. When it comes to drug interactions, you want to increase the loss of potassium. The increased loss of potassium can result from use of the thiazides and the loop diuretics if the patient is taking some type of corticosteroid or certain antibiotics. So, um, um, where I'm at, for patients with bipolar illnesses, especially if they're using lithium, the sodium intake caused by diuretics can increase the risk for lithium toxicity because of the loss of the sodium. And so therefore that's another lab that has to be carefully taken into consideration. And so you want to make sure if your patient has a bipolar disease, you want to make sure, they're on lithium and they're on a diuretic, they're going to lose that sodium. So therefore, they're going to have that lithium toxicity. So the patient taking potassium sparing diuretics should also avoid salt substitutes to decrease the risk of hyperkalemia. Okay. And also, if the potassium level is too high, it can be life-threatening. Because it causes dysrhythmias. Okay, so again, you want to look at the implications and the patient teachings, the assessment, the planning. Your book gives a really great chart in regards to gives a really great chart in regards to sources of high and very high potassium foods. So kind of you can look at that. And so now let's look at drugs for benign prostatic hyperplasia. So when you think of benign prostatic hyperplasia, you already know what the area is. It's the prostate gland, and it's in men. So when the prostate gland becomes very large, the patient's going to have difficult problems urinating because of that pressure is placing on the bladder and also the urethra. So the doctor wants to place the patient on like a drug management to kind of really decrease the smooth muscle, so it can, so the patient won't have that problem passing urine. So therefore they want to get the prostate gland, the smooth muscle and everything else to kind of decrease. Your book says drugs used in management of BPH are the alpha adrenergic receptor blockers that stop the barriers, that stop everything, that relax the smooth muscle of the prostate and bladder outlet, and testosterone inhibitors that shrink the prostate. So both types of drugs can help the patients pass urine more easily. So let's look at some of these drugs, okay? Your book does give a picture of a normal prostate versus a abnormal enlarged prostate, so it's really great for it to look at, and you can see how with the enlarged prostate, how it presses against the urethra, causing that blockage. So you have common drugs that you can actually, you know, to use. Okay. Um, I hate these slides. I hate these slides. Okay. So you have common drugs that you can actually use. So the common drugs for the benign prostatic hyperplasia, you will be the DHT group of inhibitors, okay? So these drugs, they're going to shrink the prostate by working as a counterfeit drugs that looks like the testosterone and binds to the enzyme that normally converts testosterone to DHT. It's most powerful, which is the most powerful form for of for that testosterone. So with less DHT in the prostate, the cells do not receive the signal to grow. So as a result, the gland shrinks and puts less pressure on the urethra, allowing better urine flow. Okay. So you want that DHT. So you want to decrease the amount of like that testosterone telling like the prostate to, to grow, to become humongous like the testosterone does with the men masculinity and so forth. So the drugs that you will see in that category will be your Avodart, and your postcard, or the finasteride. So teach your patient that the most common side effects of these drugs is to decrease interest in sexual activity, because knowing about those side effects is going to reduce the anxiety that they have, and they probably would think it's a different problem, but for them to know that it's a drug is okay because they won't be on it that long. Also, you want to warn patients and family members that pregnant women should not handle or touch these drugs because they can cause birth defects when absorbed in the skin. And, to being a nice mother or the wife you are, you'll give your husband his medication, make sure that he takes it, because, men hardly be on time and take their drugs. She could be pregnant, put it in her hand, and again, it can go through the skin. So great patient teaching for that. Then you're going to have your selective alpha blockers, and what they do, they relax the smooth muscle tissue in the prostate gland. So the neck of the bladder and the urethra, by binding to the alpha adrenergic receptors in these tissues. So when the receptors are activated, the smooth muscles constrict, and tightening the prostate, which increases the pressure and squeezes the urethra. So when these receptors are bound to the selective alpha blockers, so it begins to relax that area, causing less pressure and around the urethra, and it's going to give it that good flow that they need to urinate. And the drugs you will see is Flomax. That's one of them. That's tamoxifen. So you want to ask the patients who's taking the tamoxifen whether they have allergies to any type of sulfur whatsoever, because it does have sulfonamide, and this can cause an allergic reaction to anyone who actually has allergies to sulfur. And also, and when patients, change positions, you tell them to change it slowly, because these drugs itself can actually lower the patient's blood pressure. So what other categories do we have of drugs for the urine? We also have, I don't like these slides because it doesn't tell me everything. So bladder and anesthetics. So bladder anesthetics are drugs that when they're taken orally and they're excreted into the urine, they act like a local anesthetic. So you will see some of these that's going to kind of cause, like if some men have some type of, not an infection or anything of sort, but more like a burning, pain, and urinary frequency that's often results, it can be a UTI, urinary tract infection. So they're giving some type of like a sort of like an aspirin to kind of relieve that pain. and that so anesthetizing, in other words. So so there it's called phenylzyperidine. And one of the main things you want to tell your patients is that they warn them that the urine is going to come out like an orangey color, and it can stain their clothing, and it can also, stain the toilet or stain any leakage or wherever sheets where they may see that. So usually this only is that type of medicine is only maybe used for like 2 days. And if the patient still has the irritation after 2 days, you want to notify the healthcare provider. You also have drugs for overactive bladder, which is right here. And there we go. So there we go. There's a phenylzyprine, what I was telling you about, the patient about the color of the urine. And then you have your overactive bladder. So the overactive bladder, or the OAB, is going to be a problem, and especially when patients older. You see a lot of urinary incontinence because they suddenly can't control their urine. They're urinating on themselves. Sometimes when they come into a nursing home facility, you usually try to do the bladder training. Sometimes if that doesn't work, they usually resort to like some type of medication that can actually help them. What are some of those medications? In the category it would fall under would be the urinary antispasmodic drugs. So these inhibit voluntary nerve-induced contractions of the muscles there in the bladder wall, which is going to allow the bladder to relax and hold more urine without the strong urge to urinate. Okay, so those drugs that fall in that category would be the ditropans, your detrols, your enablex, so you'll see all of that. And one of the things, the nursing implications you want to tell the patient would be, tell a patient the common side effects, which include the dry mouth and dry eyes, headaches, and constipations, because again, knowing that will be really good for them to know. And also another one, you want to teach patients to avoid consuming alcohol within 2 hours of these drugs, because side effects such as drowsiness are increased. Okay, so that's the urinary part of it. Then I'll go into the drugs that affect the cardiovascular system live when we come back. Okay. Zoom recording. Okay. So I already take the urinary part of it. So I'm going to go through the drugs that affect the cardiovascular system so I can get you guys going out of here. And then I've got to figure out a way to get all this up and loaded so you can listen to it, and so I can make this class much better and more useful for you. Okay, so this whole thing here on this slide, those of you who probably printed out the packet or going, okay, is the bell ringing here to get, oh, I do get a bell on. I forgot I did put it on. Don't see anybody coming in. Okay, all right. So, so the adrenergic inhibitors, basically what this does, this part of your slide is going to talk about all that stuff we talked about earlier, so I'm not going to really go through it. It's just kind of going to give you the basis on what the actions of the adrenergic inhibitors do, and the betas and what they do. I went through this probably like so many times, telling you about the cholinergic effects, how they can cause increase in blood pressure, but when you have the inhibitors and they come in, it's going to do the opposite. So this is what this is about on your slide. So I'll have to go through it again. And this is what the angiotensins do. They, same thing, increase the blood pressures, decrease the blood pressure, so they kind of work together. So now I am going, so this part of your slide, and I'm only going through this because for some reason, whoever made the slides, it's like, it doesn't correlate with, like the book chapters and everything else. So this should have been placed after talking about the urinary tract, system. But, and then, it also, so this part of your slide, it goes to the antihypertensives and the diuretics, but I already discussed all of that and the urinary part, of the slide. So now we're going to go into, um, cardiovascular system. This here is a Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure. So when it comes to the high blood pressure, the first thing you want to do before you even placing the patient on medication, unless it's like really chronic hypertension, you want to make sure that the lifestyle changes are like in effect. Like when you're doing the assessment on your patient, when you talking to the patient in a clinic or wherever you're at, or it could be like one of those, sometimes they have students, now because it's COVID, sometimes we set up like have students go to do blood pressure treatment clinics and all the fun stuff that we used to do before the pandemic. You would talk to the patients about lifestyle changes when and the different things. But changing their diet, changing their foods, changing this like the sodium intake and potassium and and so forth, a lot of things that can cause them to have issues. Then when you go into the stage 2, that's going to be the drug therapy, and this is what we're going to actually be talking about, that part, the drug therapy. And so the drug therapy, we're going to look at the adverse reactions, the specific drugs, drug interactions, and so forth when it comes to the blood pressure medicine. Okay, so one of the first ones, so we're going to go into the antihyperliptics because that's one of the categories of ways to kind of get the blood to flow a little bit more, because you want to get rid of those fatty deposits, which are the lipids, which are the fats. Okay, so, and that's the way, because you want to get the cardiovascular system working again. And again, it's related to a lot of the patient's lifestyle and so forth that can cause these issues. So your primary purpose of the cardiovascular system is going to be to supply oxygenated blood. And, that includes the water, the plasma, the nutrients, and the hormones, all that's good stuff that we want to have. And then, as the circulation flows and go on, you want to remove the carbon dioxide and the waste products and everything else for elimination. So if the cardiovascular system is not functioning the right way, this is when you're going to get a lot of those symptoms, and it's going to decrease the patient's quality of life, and this can lead to death, and you don't want that to happen. So it's really good, when you're doing your patient evaluation or assessment, getting all this information from them so we can see what changes they really need to be made, where we can actually get started. Your book is going to show you the cardiovascular system. It's going to go over that, but you can do that on your own because you already did that all in med-surg. So now we're just trying to fix things to make it better with medication and, what we can do, because the lifestyle changes apparently is not really working for this patient at this time. Um, so so as healthcare providers, again, we do all these different approaches and treatment modalities and everything else. So you have some major risk factors for cardiovascular disease. One of them is high levels of blood lipids, and the other one is hypertension. And and these can lead to like fatty deposits of you know, and hardening of the arteries, or AKA atherosclerosis. So, and with the atherosclerosis is when you're going to see the blocks happening and blood flows and, and so forth within your heart, and, with the blood flow of the heart. So these are different things, that you're going to look at with why the medication is needed and what it's going to do. In your book, it shows you in figure 8.6 about like the normals and the blood flows of the arteries and what happens if it gets narrowed due to the plaque and the clogging and everything else and so forth. Um, so any type of any type of decreased blood flow through the coronary arteries that supply the heart muscle with oxygen, if that happens, it can cause ischemia, which is a lack of oxygen to the tissue. And if you can, sometimes a patient may complain of angina, which is some type of pain within that area. In order to treat angina, so your book describes the way to treat angina. So treating angina, like select cardiovascular drugs so it can help dilate and widen, because you want to get that great flow and you want to get that oxygen back to the heart to prevent ischemia or lack of oxygen from happening. So if the blood flow is severely impaired through the coronary arteries, or if there's a clot formation, or what's going to happen? The patient is going to experience what we call the myocardial infarction, which you also know as a heart attack. And again, that's going to result from lack of oxygen and everything helping that heart to pump and get along. So, you know, eventually it's everything we are talking about right now is going to lead to what we call heart failure. And the way heart failure is managed is using a variety of different drugs to improve the ability for the heart to pump, and to reduce a lot of those symptoms. So, and so also as an additional result to that, the heart, pumps. We talked about the lipids, but another thing that the heart does is it's like uh, how it's like a pacemaker. It's electrical conduction system. So sometimes people have dysrhythmias, which can affect, dysrhythmia is abnormal heart rhythms. So these dysrhythmias can cause a significant decrease in the cardiac output. And again, even death, if it's not, even the patient can die. They can die from this, because if it's not managed effectively. So a number of so you have cardiovascular drugs for that can restore the normal heart rhythms, and this is what we want to do. So so, so when we look at all of this, we look at the different types of common cardiovascular drugs that the patient can use. And you're going to see this different categories. You're going to see the hyperlipidemics, which is right here, the antihypertensives, drugs for the angina pain that the patient usually complains about, especially if it's not enough oxygen going to the cells. Drugs for any particular heart failure, and also the anti-dysrhythmic drugs. So those are the most common types of cardiovascular drugs that you have. So let's look at the hyperlipidemics really quick. So the hyperlipidemics, like lipid, is right there. So you're going to see the word fat. You're going to see triglycerides. You're going to think of all of that. You're going to see all of those are the labs you're going to be looking at when it comes to the hyperlipidemics, the LDLs, the bad cholesterols, and the HDLs, the great cholesterols, the ones that you really want to have. So the hyperlipidemia is the condition level of high levels of lipids, cholesterol. When you think of lipids, think of primarily cholesterol or any type of fatty acids. When you use the term antihyperlipidemics, those are the terms you say, oh, that's a drug that's going to lower my cholesterol. So those are the drugs, okay? So your body, your body is going to need cholesterol. It's not like we shouldn't have any cholesterol at all. The body needs it because, certain cholesterols are really healthy for the cell membranes, for your hormones, for the vitamin Ds, for the bile acids. So you want to have this as a normal part in your body, like with the blood plasma. It's not like you want to get rid of all your cholesterol, but it does, if it gets to the overabundance, because the liver, the liver is part of this. The liver is part of building up the cholesterol, your cholesterol. So your liver produces much of the body's cholesterols. This is an excerpt. This is from your book. So the liver produces much of the body's cholesterol. Therefore, when you think about cholesterol levels, you need to recognize that the levels are a combination of the cholesterol ingested in the diet and the cholesterol that's produced by the liver. it is important to note that though it is important to note though that the liver contributes much more of the cholesterol to blood cholesterol levels than it does to the food you eat. Okay, so you have your blood lipids and the
Excuse me, sorry, I'm
cholesterol.
finally in.
Hello. Okay. So you have your lipids, your regular you have all your lipids, and these are, so your lipids, the cholesterols and your other fatty acids, they move through the body attached to protein carriers that's going to carry them, and these are called your lipoproteins. So when you think of cardiovascular disease, or if you think of the hardening of the arteries, it is most important, it's the most important lipoproteins that are really high density proteins. So those are your HDLs, and you know, and those are the good ones. Those are the protected ones. But when you think of the LDLs, and some people say, oh, the LDLs, those are low. Those should be really, really great. No, those are more harmful than anything. The HDLs are the better ones. So H for high is good. High for happy. So that's the good one. Okay. So as you think about drugs for reducing cholesterol, you consider the effect of the drug on the good cholesterol, which is the protective cholesterol, which is the HDL, or the bad cholesterol is the harmful, again, for the LDLs. So um, and that's a good memory jogger. LDLs are the bad cholesterols and HDLs are the good cholesterols. So for some patients, the lipids, are improved through, diet and exercise and so forth. For others, may require some type of like anti-hypolipidemic, just to kind of get through life itself. So most lipid lowering drugs tend to reduce the bad LDLs, the bad ones, and other fatty acids, and some drugs actually increase the HDL, um, you know, the high that one. So your book describes it like a scavenger, like a little, like what's those catfishes. So the HDL is actually the catfish. The HDL is the one that goes around and picks up the food and makes sure everything is nice and clean inside the body and everything else. Some of these drugs that they take, if your HDL levels seem like it's not really at a good level, they'll give you drugs for that so it can start elevating your HDL, so your HDL can start working a lot better. And then on the opposite side, some other drugs with the bad LDLs, they tend to work on that one so it won't go up too high because it's not doing anything. It's actually just collecting the cholesterol and not really helping the body at all. So what kind of drugs do you have? So you have 5 classes of the anti-hypolipidemics. Um, and we're going to look at that. And so you have the HMG reductase inhibitors, you have the cholesterol absorption inhibitors, you have the fibric acid derivatives, and the bowel sequestrants, and the niacins and the nicotine. Those are all your um, you know um, anti-hypolipidemics. So again, not to go through too much with the actions of it, but you just make sure you read through it so you can kind of understand the actions for what they actually do. Like I explained it a little bit to you. So so when you're looking at the categories, the common HMG CoA reductase inhibitors, those are your statins. Okay, so those are your drugs that fall under statins, and you have a whole bunch of those. One of them is Lipitor, and one of them is you have the Pravicols, and you have your Crestors and your Zocors. All of those are statins. When you look at the generic name of it, each of those generic names is going to have statin at the end of it. For example, Zocor, you have the simvastatin. You have that. You have the atorvastatin for the Lipitor. So all your statins is actually going to have statins at the end of it. So just think of statins as my hyperlipidemic drug that's going to lower my cholesterol levels. So the way the statins work, they do it by slowing the liver production of cholesterol. And they do not remove dietary cholesterol from the blood. They just basically slow the liver production of cholesterol, because remember, the liver is the one that actually can, your natural way of producing it. That when you eat all the fatty foods, that's you throwing all that in your body. So now we're trying to reduce the cholesterol level by slowing the way the liver produces the cholesterol. So when you're taking those medications, you're looking at the nursing implications of them. One of them, I'm only going to give you one nursing implications for each of these drugs now, so I can kind of get going here. So I want to keep you all today. It's a lot in the cardiovascular system. So the nursing implication, one of them is to remind the patients to remain on a low cholesterol diet while taking statins, because drugs do not reverse a high cholesterol diet, okay? So remind the patient on a low cholesterol diet again while taking statins. You want them to remain on a low cholesterol diet so this drug can actually work, okay? So again, you have your uses, like we went through that in your expected side effects from these drugs. Again, your patient, if they complain of abdominal pain, headache, diarrhea, those are some expected side effects from this drug. And if it's a long-term use of statins, it can be associated with some type of cataract formation. This is just some studies that actually said that. So but your book also says the benefit of a statin use does outweigh the risk of cataract. So it's not like, oh, let me not give this patient, he can go blind, he can get the cataracts, and this. No, it's really good for them to have the cholesterol to lower that. Then of course you're going to have some adverse effects, and sometimes the patient may have signs and symptoms of the muscle pain, the muscle sores, which we call rhabdomyolysis, and they get the muscle weakness, the stomach pain. Sometimes it might be even a change in the urine color, like a tea-colored urine. So the brown urine basically results from the kidneys trying to filter out the products of the muscle breakdown and all this other stuff that's going on when you're using some of these statins. So statins can be very dangerous to a pregnant person during pregnancy. So statins are dangerous if used during pregnancy. Cholesterol is important for normal brain development. So if you're pulling out cholesterol and the baby is, the mother is pregnant, you don't want her to take any of these cholesterol pills, because again, it's important for normal brain development. So you need that cholesterol. So if during pregnancy, if taken during pregnancy, again, statins lower the cholesterol levels of the fetus, which results in brain deformities. So for the same reasons, it's going to be contraindicated if the mother is breastfeeding. So you want to make sure, that's one of your considerations when you're looking at the meds, when you're doing your assessment, when you're doing your care plan and implementing. Again, it's very important when you're doing your assessment. Looking at the dietary, looking at whether or not the mother is pregnant. So you're looking at all of that, because now you have to come up with a plan of care, intervention, and so forth. So while on the statin therapy, patients may have a scheduled blood lipid therapy, like they're checking the levels of they're checking, the doctor may order for labs, the HDL, the LDL, so they're going to order all of that. And usually when they order these labs, you want your patient to fast for at least 12 hours before having the cholesterol and the HDL level and triglycerides level drawn, because you want a true lab. You want to see what happened, within that time frame, because you want to go back in time and let the blood work, everything kind of derived from back in time to see, to get a true report instead of a false report of what's going on. And also, even when you're administering a statin, it's very important. Sometimes it's best for it to be taken in the evening, because some of them work better in the evening, and some maybe work better once a day, taking, with the meals or so forth, or twice a day. But one of the things you don't want to do, you do not give the drug with grapefruit juice, because this drug is going to inhibit the drug breakdown. So you don't want to give this with grapefruit juice. And as always, you always want to make sure you're evaluating your patient while they're taking this drug. So, you know, you're going to monitor for the expected side effects, such as the headache and the upset stomach and so forth. And also you want to check your patient for jaundice, which is the yellow discoloration of the skin that one may get. And even sometimes they may have yellow discoloration in their eye. And you're also looking at the darkened urine and the clay colored stool, because it can, because you remember, we're looking at the liver now, because the liver builds up, with the cholesterol. So any drug that's gonna involve the liver, you always want to look for, check for jaundice or anything like liver toxicity, which is also AKA toxicity, hepatotoxicity, sorry. So all patients taking statins usually have like a regular liver function studies after starting the drug, and then yearly and whenever symptoms occur, okay? So those are your hyperlipidemics. So now, even though with the hyperlipidemics, those are the statin drugs that we were talking about. So some people don't do well with statin drugs, so therefore they have to go and use a non-statin drug, because to reducing like the blood cholesterol levels. So some people may have to actually use that. And your book does go through some of it, like they have the selective cholesterol absorption inhibitors and some other inhibitors that you can kind of just make sure you just read and go through. It also talks about like niacin and the niacin or nicotinic acid, um, you know, so make sure you just kind of briefly just read up on that too. So with the niacin, you may have heard of niacin. It's like a vitamin B complex vitamin. It's found in animals and plants like that. It can also lower total cholesterol, the LDLs, and it can increase the HDLs, which can help, pick up the cholesterol up there. So you want to just kind of read up a little bit on that, and the assessments and planning, implementation, and evaluation in regards to those non-statin drugs, okay? So let's look at the antihypertensive drugs. So you have the antihypertensive drugs, and the name is like what it says. Hypertension means high blood pressure. Antihypertension means going against it. So you have the blood pressure, the blood pressure is the pressure of the circulating bloods of the wall and the arteries and the veins as the blood moves through the body with each contraction and relaxing the heart. So a really great healthy blood pressure maintains the circulation and so forth. So any blood pressure that's going to get too high or too low, again, it's going to cause those problems, those issues. It's going to affect the blood vessels, it's going to affect the organs, it's going to affect the tissues. So many things can affect the blood pressure, including the heart rate and how well the heart actually contracts, and certain hormones, blood volumes, and the activities, the stress, and everything else. So when a patient does have high blood pressure or hypertension or HTN, which is abbreviated for hypertension, this is a disorder in which the patient's blood pressure is consistently elevated above the values and everything else. So in your book, and it's really great to have this table, it's a blood pressure classification. So make sure you take a note of that. This is table 8.5. It's going to show you your norms. It's going to show you what the elevated. It's going to show you stage 1 hypertension and stage 2 and what the reading should be and what the norms are. Also, box 8.2, it talks about the recommended lifestyle for patients with high blood pressure. And like stop smoking, have a well-balanced diet, maintain a healthy weight, okay? So again, your antihypertensives are, again, these are drugs that have the main purpose of making the blood pressure lower. These drugs are prescribed on combination with, and we're going to look at these categories quickly. It's the angiotensin converting enzyme inhibitors, that, inhibitors mean to stop, and the angiotensin 2 receptor, those blockers. And So you want to, we're going to look at those. We're going to look at the different drugs. In your book, it talks about, it says, for African American patients, the thiazide diuretics and the calcium channel blockers are used alone or in combination for best management. For patients with diabetes and chronic kidney disease, the and ACE, IS, and ACE inhibitors and the ARBs are used for those particular patients. Additional classes of drugs used on management of the high blood pressure most commonly include beta blockers, alpha blockers, alpha and agonists, combined with the alpha and the beta blockers and the vasodilators. So we're going to look at those different categories of drugs for the blood pressure. And another thing they have in your book is really great. I really like your book. It's good. Box 8.3, it shows you about the general nursing implications for antihypertensive drug therapy and how to go about the assessment and how to do your whole planning and your implementation and how to go about monitoring your patients. Right here, it talks about the different beta blockers, the actions of the beta blockers on this screen here, and the uses and the side effects, and also your nursing interventions. But the chart that's inside your book is really great. It's something for you to look. Here it talks about how the ACE inhibitors work. And by the way, it blocks the angiotensin, and to convert to the angiotensin 1 and 2, that can help lower the blood pressure. Okay, and it goes about that in your book too. So in your book, where am I? So again, the antihypertensive drugs, they have the following main categories. Again, they fall into the diuretic category for diuretics, so we spoke about earlier. The renin angiotensin drugs, which work by decreasing vasoconstriction and decreasing fluid volumes and decrease blood pressure through the ACE and the ARBs. Then you have your calcium channel blockers. They work by relaxing the smooth muscles and the coronary and systemic arteries, and it's going to lead to decreased peripheral resistance, which means if you have that decreased peripheral resistance, like pushing and pressure, it's going to help lower the blood pressure. Okay. Then you have the adrenergic agents, which is used for the treatment of high blood pressure. And it affects the epinephrine and the norepinephrine neurotransmitters, which is in the nervous system. So depending on the receptor, these drugs can decrease the vasoconstriction. Remember, constriction means tight, and it can also decrease contractility of the heart. So all of that, all that work is so all of that, again, it's going to help lower and decrease your blood pressure. Okay. And number 5, you have the vasodilators directly affect the arterial and venous system to decrease peripheral resistance. So your common antihypertensive drugs, again, you're going to have those diuretics. We talked about how diuretics worked earlier because I taped it earlier with the urinary. So you're going to have those diuretics that's going to work along, with lowering your blood pressure. You have your RAAS drugs, which are the renin angiotensin aldosterone system. So drugs work by decreasing the vasoconstriction and decrease fluid volume to decrease the blood pressure. And all of that is going to fall. Those drugs, you will hear names like Caterpillar, enalapril, lisinopril, quinapril. And all those drugs right there are, those are going to be in your renin and renal angiotensin aldosterone system, the RAAS. Then you have those are your ACE, IS, and you have your ARBs, and all of them are your losartans and your, valsartans. You have all of those. So I'm going to make sure I attach a video to the announcement today so you can look at this. It's a great video. It's going to tell you how to kind of separate your drugs in regards to the cardiovascular drugs. So it's really good. It'll show you really great tricks to how to remember these categories and medications. And of course, you're going to have your nursing implications. Again, one of them is teach patients that these drugs can have a first dose effect, leading to an increase of falls and dizziness. So when they first start taking it, they might feel lightheaded because, again, it's helping to lower the blood pressure. Then you have your calcium channel blocking agents, and those are your Norvasc, your cortisones, and so forth. So you have all of those, and all of those, the calcium channel blockers, the majority of those end in PINE, like lopidine, and then you have falopidine. You have your narcotidipine. So you have all those that end in the pine. And of course, with the nursing implication, you want to avoid changes in position because most antihypertensive drugs can cause orthostatic hypotension. So this is really great that when your patient comes in, you're going to get their orthostatic hypotension. You're going to take an orthostatic hypertension or hypertension the blood pressure, and you want to make sure you keep that as your baseline so you can see that. And they have some more nursing implications that you can look at it and make sure you go through that. Then you have your under the category for adrenergic agents, which again is used to treat hypertension. It affects the nervous system control of various organs and tissue by activating or either blocking receptors that respond to the body's natural adrenergic substances such as the epinephrine and the norepinephrine, which makes you feel like woo, and then pump it up, and so your blood pressure can actually kind of drops in a way, drop with that. So increase with that. So you have the beta blockers for that category. You have in those categories with the beta blockers, a lot of them tend to end with the LOL, like laugh out loud. So LOL, metoprolol, nadolol, propranolol. So you have all of those that fall under your beta blockers. So again, you want to look at all your nursing implications for both of those. With the beta blocker, you want to make sure that the drug is going to be held if the heartbeats are less than 60 beats per minute, or systolic pressure is less than 90 to prevent any type of adverse effects. And then under the same category of the adrenergic agents, again, you have the beta blockers, the alpha blockers. Do you have the alpha beta blockers and the alpha agonists? So all those fall under that category together. So again, even though they all fall under that category together, you want to make sure that when you're looking for the nursing implications for each of them, some of their nursing implications are a little bit different. Okay, so you want to make a note of that. Vasodilators directly affect the arterial and or venous system to help decrease peripheral resistance. So you have your vasodilators, and those are gonna, you have your hydrolizine, your minoxidil. So you have those. One of the nursing implications would be to teach the patient to weigh themselves every day and to report swelling of the hands and feet to their healthcare provider, because again, these fall under the vasodilator. So they directly affect the arterial and also the venous system to decrease peripheral resistance. And you also want to remind patients to take the drug at the same time every day, because it's important to avoid missing a dose, because missed dose can cause a rebound of high blood pressure. And again, you're going to be monitoring the patient's, any type of drop in blood pressure. So again, you want to make sure you look at your memory joggers. And it's really great because it's going to tell you what I just said to you, that some of the drugs typically, like for example, the ACE1 drugs, they typically use the suffix PRIL, like the Caterpillars and the Prenavils and so forth. Okay. And Okay, let's see, here we go. And we just went through all of that because I just said to you the different meds and alpha blocker actions. Okay, so now we're going to go into the anginals and the peripheral vasodilators. Okay, and just get there. So angina and so anginals and peripheral dilators. So with the not anginals, the anti-anginals. So basically, the drugs for anti-angina and myocardial infarction. So you have the coronary arteries supply, that supplies blood and the oxygen and everything else and the nutrients to the body. So for patients with any type of atherosclerosis or plaque within the blood vessels, again, is going to lead to what everything I just said before, a blockage, no oxygen or anything going to the heart. So partial blood flow to the heart muscle can lead to the lack of oxygen and that chest pain we talked about earlier, which could be angina. And, and if it continues, it can, the flow continues to be reduced, it can lead to a heart attack. So you have those are your so you have the you're gonna have those categories with the anti-anginal drugs, and most of those drugs are managed. Those class of drugs are used to manage. Um, you know, uh, the drugs, the categories would be your nitrates, your beta blockers, your calcium channel blockers, and all these drugs can improve circulation and reduce the cardiac workload, which is going to help, which is going to help reduce any type of decreased oxygen going to the heart, which can prevent a myocardial infarction. Okay, so let's look at those drugs. So those drugs, okay. Before we go to those drugs, in your book, box 8.4, it talks about patient education for taking a nitroglycerin tab, which is a nitrate. And those nitrates, the action of a nitrate is so the nitrates are a class of drugs that basically they widen the blood vessels, and to get that, they widen the blood, they widen it, and they do that by relaxing the vascular smooth muscles in the peripheral venous system and reducing the resistance to blood flow in the arterial system. So when you're relaxing the smooth muscles in the veins, it helps to increase the pooling of that venous blood. So therefore, it's going to decrease the amount of blood return to the heart of preload. So when you want to relax the arterial, so relaxing the arterial system decreases the pressure the heart has to pump against the afterload. So these effects work together to help the heart receive more oxygen and pump more easily. So when you're using those nitrates, like the nitroglycerin tabs, and sometimes they give it intravenous nitroglycerin. They're used to relieve the pain in in acute angina. Long-acting oral nitrates, like topical nitrates, sometimes you might see it put on a patch or a paste, or a transdermal patch. It can prevent angina, and also it can reduce the severity and frequency of the patient having those frequent anginal attacks. And the nitrates also reduce the work of the heart after patient has some type of MI, or patients who have heart failure. And again, your expected side effect with the nitrates, when they take it, the patient's going to say, I have a throbbing headache. It doesn't last long, but they're going to complain of that throbbing headache. That's one of the side effects of taking a nitrate. Your book does have the patient education for taking nitroglycerin, and also a spray or a nitroglycerin sublingually, and or a spray for any type of onset of chest pain. So make sure you look at that. It's very important. Okay. And also, when you're really great top tip for giving a nitrate, the patient, you want to make sure the patient wears gloves to apply nitroglycerin paste to avoid absorbing it through their skin. You don't want anything to happen. So you're going to have your common anti-anginal drugs that fall under the nitrate category. One of them again is the nitroglycerin. And again, you remember, where you want to wear gloves. You want to, let the patient know they may experience a really bad headache. And there's also some other implications. When we're looking at the calcium channel blockers or the beta blockers, um, again, you we went through those with the other regards to the other medication we just went through with the different heart high blood pressure medicines. So you can just go back and refer to that because it's the same exact information. Now you have your dysrhythmic drugs. Okay, nitrates. We went through the nitrates, calcium channel blockers. We went through all that already. Did we go through? No. So now we're looking at the cardiac conduction, which is going to fall under your anti-dysrhythmic drug category. When we said the heart is like electrical conduction and so forth and everything else. So the action for these antidysrhythmics, these drugs work to make the heart rhythm more regularly and reduce any type of serious dysrhythmias. So these antidysrhythmic drugs fall under the classification. It's using a Vaughan-Williams classification system. So this system helps organize the drugs according to where they act in the conduction cycle. So you have the class 1s all the way to the class 4s, and then you have the others, which includes the digoxins and also your magnesium sulfates. So we're going to look at those, but the uses again for those would be the cause of dysrhythmia. It determines which class drug. So depending on the dysrhythmia, it's going to depend on the category of the drugs the patient's going to receive. Just a little excerpt from your book. It says the digoxin is primarily to treat heart failure, but also plays a role in treating fast dysrhythmias, such as atrial fibrillation or supraventricular tachycardia. It slows the heart rate by slowing how fast the sinoatrial node fires, and it also slows the conduction through the atrioventricular node. It also strengthens the contraction of the heart, and toxic levels of this drug causes dysrhythmia. So other drugs that affect heart activity are the beta adrenergic blockers such as sotalol and the acebutolol. So drugs in this class act very much like quinidine on the heart, but they also decrease the response of the heart muscle, to epinephrine and norepinephrine, which are the chemical neurotransmitters. And they do this by blocking the stimulation of the heart's beta receptors. So that's just a little snippet from your book. So these digoxins, so if your patient is on digoxin, of course, because of that, it can cause a toxicity. So therefore, that'll be one lab that you'll make sure that you're doing for your patient. So you have your common antidysrhythmic drugs. Like I just said, you have your quinidines, and the quinidines, those fall under the sodium channel blockers. So you want to, look at, again, that it falls under the sodium channel blockers. Your nursing implications, you want to teach the patients to avoid any over-the-counter drugs to prevent any type of dangerous interactions. So that's one of them. Do you have drugs that fall under the beta blocker category? And those drugs, again, one of them is this sotalol. And you want to monitor the patient's heart rate and blood pressure. And you want to hold the drug if the heart rate is less than 60 or if the blood pressure is less than 90. So you want to do that. Then you're going to have your potassium channel blockers, which will be your amiodarone. So you have those. And again, the potassium channel blockers, they make cells less excitable and reduce the heart rate. They often help to convert the atrial fibrillation, atrial flutter to normal sinus rhythm. And they can also be used to treat dangerous ventricular dysrhythmias. So one of them, you want to, again, you want to be sure to monitor the respiratory status of the patients who are taking this because it can cause some type of pulmonary complication. And your other calcium channel blockers, you know, you have your cortisons and your verapamils that fall under this. And again, you're looking at you want to avoid sudden changes in the positioning and so forth. And you want to remind patients to keep taking the drugs that's prescribed because they do not cure high blood pressure. So you want to continue, that's like one drug that's continue. So in your cardiac glycosides, it decreases the speed of conduction through the atrioventricular node by decreasing the number of atrial polarizations and slow the ventricular rate. And that's your digoxin. And it's a pretty great medication. It's a pretty strong medication. But again, you are making sure that you're getting the blood work done and the blood levels. So if the patient is experiencing any symptoms of digoxin toxicity, you want to make sure to contact the healthcare provider. And the optimum blood level ranges should be between 0.5 and also, you know, 0.8. And again, all these drugs, looking at the assessment when the patient is coming in, getting the patient's history. You're checking the patient's heart rate when you're checking it, not by radio. You want to do a regular stethoscope, getting the heart rate because you want to make sure that you're checking the heart rate correctly, getting the proper number. Again, you're planning an implementation, making sure that the healthcare providers get some of these medicines before that. Maybe a ECG or which is electrocardiogram, you want to get that. This test will help the provider determine how well the drug is actually working because it's a conduction drug. Those drugs, you know, it works on the heart, the impulses of the heart, okay? So in addition, you want to take the baseline and follow up vital signs when you are giving these antidysrhythmic drugs. In some settings, you may have the responsibility of monitoring the changes of the blood pressure, or pulse, and so forth. And of course, when a patient is taking these medications and you're doing the evaluation, you want to make sure you're monitoring the patients being monitored, especially if they're in a telemetry unit. You know, and so they're doing that. And of course, you have the your nursing implications. So another category of drugs is your cardiotonics. And your cardiotonics, again, it's more like the contractibility of the heart muscle. And, you know, so so these drugs, again, where is it? My list of drugs, where is the drugs? Okay, sorry, I'm just going back in my notes. So those drugs are cardiotonics. Where is it? Okay, just lost it. Okay, so those drugs, so the term, the it says cardiotonics, but the term is inotropic drugs, your inotropic drugs. It's just, again, it's used to describe the contractility of the heart, and you know, and a drug that is and it's a drug that is a positive inotrope. It's going to increase contractility. A negative inotropic drug decreases contractility, and so in heart failure, you want the positive ones to help increase the contractility. In other words, they increase the ability of the heart to pump. And this is what you want. So again, and what you can read through the adverse reactions of these drugs, and you know, and the use of it. You know, so positive inotropic drugs are primarily used for symptom management in patients with an advanced heart failure, and also in critical care areas to help increase contractility of the heart muscles and provide cardiac output. The adverse reactions, again, you want to make sure you're checking the DIG levels, so for digitalis toxicity, the amount of medication that is helpful and the therapeutic amount that is harmful. And toxic are not very different. And you also don't want to confuse the sound like digoxin and digitoxin because it's different. And also when it comes to drug interactions, um, you know, um, your book says the beta adrenergic blocking agents like the calcium gluconates, the calcium chlorides, the verapamids, they increase both the therapeutic and also toxic effects of the inotropic drugs. So any drugs that change the electrolyte balance may also lead to some type of digoxin toxicity. So in particular, patients who take drugs that reduce potassium levels, such as diuretics, are particularly susceptible to having a digoxin toxicity. And for a safety tip, your book talks about digoxin, and about it says remember the rules for leading and trailing zeros when giving digoxin. So the usual dosage of the digoxin adults is very small compared to other drugs. So when you see the digoxin drugs, it's going to say 0.125 to probably 0.25, but the dosage is very small. And once again, make sure you read on the evaluation and also the patient teaching, okay? So you can kind of get understand the medication. Okay, and they do give you some nursing implication and patient teaching here about checking the pulse before the dose, 1 minute, and use a stethoscope, please, for that. Hold pulse if it's less than 60, and you want to report the signs and symptoms of the anorexia, the nausea, the vomiting, which can lead to being like a digoxin toxicity. And the toxicity also may cause the irregular heartbeat or just dysrhythmias. Diets high in potassium unless contraindicated. And also, that's why you want to be careful if if the patients or anything, maybe if they're on a potassium sparing, you don't want to increase the potassium. If it's on another type of diuretic, you're probably going to have diets high in potassium because those diuretics tend to pull out. The patient will lose that. Digoxin levels you're looking at, digoxin toxicity can be treated with digoxin immune, which is Digabind, that, and also make sure they have a medic alert bracelet on their arm, okay? Now I'm gonna let you go home. It's 2:30. We had a lot today. So I'm gonna let you go home, but on your slides, you have these resources that you can look at. I haven't seen these slides, but you can probably highlight these slides, look at that on your own on your own time. But I'm gonna have you do that. Any questions at all? Because I'm going to post this up. I'm going to post this, try to see how I'm going to post this and put in an announcement so you can know where to find it.
And when is the discussion board due?
Remember I said I'm going to let you know next week. So don't worry about that.
No,
don't
for
worry
this
about
one
it.
too, because I know you said the same thing for maternity.
Yeah, this one too.
Okay,
so look at everything really good.
And you said that we had to just pick 2 different medications. Does it matter what it is?
So like, suppose your class, I don't want everybody to choose the same medicine. So suppose you put up, digoxin or something like that. I don't want somebody else putting it up. Just look and see what other people put up, and you find a different one. So you put yours up, but then you're going to answer 2 more classmates. You know what I mean?
Okay, and we're just doing the regular med cards, correct?
Yeah, so look at that video. It'll show you how to kind of do it. And don't put a lot. I don't want a lot of information. Just put a little bit. Let it be like authentic. Let it be you. Something that you want to know so your classmates can know, and don't bust their brains out. I don't want anyone to be like, oh, I got the best one because I did this. No, I don't need all that. Just something simple. Okay?
Okay, thank you.
Okay, any more questions? No? So do you like the Zoom better, everyone?
Yes, a lot better.
Yes.
Okay.
Yes.
Okay. So that's good to know. Okay. All right. So